Yeah, good day, class. We're going to have a few pre-recorded lectures to catch up. And the first one's going to be on the heart. We're going to cover the blood vessels. We'll move on to the reproductive system, urinary system, lymphatic system. And I think that would be about it for the remaining of the semester. So let's go ahead and start with heart. And with the heart, very important, with Chinese medicine, this is involving the Shen. Today we'll be discussing the biomedical aspect of the heart, which involves a systemic system and also a circulation system. The pulmonary circuit is the right side, receives oxygen poor blood from the body and pumps it into the lungs, where the systemic circuit, the left side, actually receives oxygen from the lungs and then pumps it throughout the body. Okay, if you can remember anything about the two functions, remember this slide. So put a check mark on this slide. You may see this again. And again, the pulmonary circuit, which is the right side, receives oxygen poor blood from the body and it pumps it to the lungs, right? And we're going to get into the atriums and the ventricles. Don't be too much worried about that right now because we'll mug it up. So just understand there's two circuits at this point, the pulmonary circuit and the systemic circuit. And here we go with the atria. So the atria is at the top of the heart. It's the two chambers up top. And the atria receive blood from the pulmonary and systemic circuits through two different valves, but we'll break it down later. And the ventricles are on the bottom. And the pumping chambers, those are the pumping chambers of the heart. Okay. So if you could imagine four chambers, the two top chambers being the atria, the two bottom chambers, the ventricle. Looking at this diagram, as you can see, you can follow it. And as you can see, the left atrium and the left ventricle. And as you can see, the left ventricle pumps out through the top of the aorta and reaches down through the left ventricle all the way down to the systemic circuit, and which your body uses all that oxygen, okay, all the way down to where they reach the capillary beds, where the oxygen has been suspended. This is where the gas exchange occurs, where oxygen poor blood passing the capillaries moves its way back up through the venous system, all the way up to the right atrium, and follows the pulmonary circuit into the lungs, where the lungs could go ahead and oxygenate that blood and bring it back to the heart to start all over again. So use this to revise both the pulmonary circuit and the systemic circuit. And so where is it located? So the heart, a healthy heart typically weighs about 300 grams, and it's the largest organ of the mediastinum, located between the lungs. And the apex lies to the left of the midline, where the base is a broad posterior, is the broad posterior surface. So as you can see, you have your mid-sternal line, this diagram here, and the top of the rib where it's level with the top of the heart, and the diaphragm, the apex of the heart actually rests right on the diaphragm, as you can see here. Over on C, you have your apex of the heart resting right there on the diaphragm. And as you can see, the pulmonary trunks are in blue. And for educational purposes, and they've colored the veins blue for you for deoxygenation, and the aorta is red for oxygen. And as you can see, the aorta and the aortic arch, you have your lungs on the left and right hand side, and the pericardium is not shown here, but it's the nice covering of the heart. And you have your diaphragm that the apex rests on. As you can see down below for autopsy picture, You can see the fat in the epicardium and the apex of the heart, again, resting on the diaphragm portion. The aorta that comes out, the aortic arch. You can actually see your left lung and your right lung, your superior vena cava. And you can't really see your inferior vena cava. It's cut off right in through there. But let's get on to the next slide. This is the location of the heart, the thorax. Again, the largest organ in the mediastinum. The four corners of the heart, you have your superior right at the costal cartilage of the third rib and the sternum. In the inferior right, at the costal cartilage of the sixth rib and lateral to the sternum. Superior left side, you have your costal cartilage of the second rib lateral to the sternum. So that's your second rib, which is the most superior portion of the heart. Then your inferior left lies in the fifth intercostal space at the mid-clavicular line. As you can see, the heart isn't exactly a square object, so even when it's tilted, you're going to have different rib levels and different levels, because not only it's not an exact shape, it's not straight up and down. So remember the rib spaces, know those costal cartilage, and those what lies lateral to the sternum, all those kind of things. So remember those reference points. They'll be coming handy later during your Western medicine courses. The structure of the heart, the coverings, you have your pericardium. You have your two primary layers of the pericardium, your fibrous pericardium, which is a strong layer of dense connective tissue. All right, so that's your strongest layer, your most outer layer. And then your serous pericardium is formed from two layers. You have your parietal layer of the serous pericardium and your visceral layer of the serous pericardium. Okay, so know those layers, know what the pericardium is there to protect the heart. But if there's bleeding in the heart, this pericardium can actually trap the blood in between the heart and this fibrous material, the pericardium, and actually reduce heart rate, actually put a lot of stress on the heart, and people have to perform a pericardial tamponade. They stick a needle in there and they withdraw the blood in between the pericardium and the heart tissue to help save the patient. This is usually to blunt trauma to the chest, car accidents, chest hits up against the steering wheel, and this is how they save the patients in the ER with a pericardial centesis. Here you have the layers of the pericardium of the heart wall. As you can see over here, as demonstrated, you have your fibrous pericardium on the outermost layer. You have your parietal layer of the serous pericardium. Then you have your pericardial cavity right in through here, which is a space or a potential space. And the epicardium, it's a visceral layer of the serous pericardium. You actually have your myocardium in through here. This is actually your heart wall. And you have your endocardium and your heart chamber down below. So there's your layers. Don't be worried so much about it right now. There's some other slides that are better aligned to actually teach this, but just to understand that the fibrous pericardium, the parietal layer, has different layers, and know the names of those different layers. Here we go. So the epicardium, again, of the heart wall is a visceral layer of the serous pericardium. It's the outermost layer of the heart wall. Then you have your muscle tissue, right? This myocardium consists of cardiac muscle, which is striated muscle, similar to that of skeletal muscle. There's two places that have striated muscle. It's skeletal muscle and cardiac muscle. And you can tell the difference because it has intercalated discs, and also they have cross striations when looking under a microscope. But it's a special type of muscle called cardiac muscle. And this muscle is arranged in a circular and spiral patterns. This is your myocardium. The endocardium is endothelium resting on a layer of connective tissue, and it lines the internal walls of the heart. So there's your layers, your epicardium, myocardium, and endocardium. The cardiac muscle bundles are are very special bundles, as you can see. And this is just a picture of the circular and spiral arrangement of the cardiac muscle bundles of the myocardium of the heart. Heart chambers, as I said before, the superior chambers are your right and left atria, and your bottom chambers are your right and left ventricles. You have internal divisions that provide communication between the atria and ventricles, called the interventricular septum and the interatrial septum. In the embryo, a lot of problems with the heart is caused by misdevelopment of these septums, and you have atrial septal defects that could affect you later on in life. Some of them are very serious, and some of them people don't even know and live their whole lives with an issue there, and only realize it later in life. So your heart chambers, the external markings, you have the coronary sulcus, the anterior interventricular sulcus, and the posterior interventricular sulcus. Let's take a look at those. So starting from the top, I want you to know anything that is bolded at this point. So your right atrium, if you cut this in half, you have your right and your left side of the heart. Although it goes at an angle, if you were to bivalve this, which we'll show you later, you'll see where the ventricles and atriums are in relationship to this orientation. You can see the right atrium is right here. The superior vena cava and the inferior vena cava bring deoxygenated blood to that right atrium. Okay, so know that. That's a item of a test question. And also, your left atrium sits above, right across from your right atrium. You have your left ventricle. This is the strongest ventricle, which pumps blood throughout the body. Okay? Get familiarized with all of these, but be more familiar with the bolded items. And as you can see, the left pulmonary artery here, okay, this is the only artery that carries deoxygenated blood. And if anybody, the superior vena cava or the right pulmonary artery, here's another one that carries deoxygenated blood, right? So let's take a look at some veins. So usually veins are blue, right? So as you can see, but these veins right here, the left pulmonary veins and the right pulmonary veins, actually carry oxygenated blood from the lungs into the left atrium. Okay, so after it gets done through that pulmonary circuit, it brings back oxygenated blood from the lungs into the left atrium, where it gets pumped into the left ventricle with oxygenated blood. And anything that goes away from the heart is actually an artery, right? And anything that comes to the heart is a vein. And this is the exception of oxygenated and deoxygenation, is that the pulmonary veins carry oxygenated blood, and the pulmonary arteries carry deoxygenated blood. Okay, so that's a pretty good overview. This is a gross anatomy. Those are the main players. We can dissect this later and get into the coronary artery. We're going to get into that when we start talking about vessels. This is going to be the next lecture. We right now understand those big major pieces of the heart. Here we go. Right atrium forms the right border of the heart. Okay, and this is the atrium. This receives oxygen poor blood from the systemic circuit through these vessels, from both the superior vena cava coming from above the heart, the inferior vena cava coming from below the heart, and actually the coronary sinus, because the heart itself has its own venous system. So the coronary sinus actually has to bring back deoxygenated blood from the heart tissue itself and bring it into where? The right atrium. Test question. The right atrium, you have your pectinate muscles. You have ridges inside the anterior of the right atrium. You have your crista terminalis, which is a landmark used to locate veins entering the right atrium, and the fossa ovalis. This is a depression in the interatrial septum, and it's a remnant of the foramen ovale, which, when in the embryo and at the beginning of when the heart starts to beat, later it becomes they start to develop septums, and there's actually an ovale. There's communications between the atrium, and this foramen ovale actually gets filled up. And this depression is actually a remnant of that. You could actually see in the adult heart. So the right ventricle receives blood from the right atrium through the right atrioventricular valve, which is the tricuspid valve. So understand that the right side of the heart, the atrioventricular valve between the atrium and the right ventricle, the right atrium and the right ventricle, is called the tricuspid valve. And this pumps blood into the pulmonary circuit, the pulmonary trunk. Okay. The internal walls of the right ventricle have the trabeculae carneae, the papillary muscles, and the chordae tendineae. And these are actually tendons within the heart. These are muscles. And this is just a piece, the trabeculae carneae is a piece that I'll show you on when we open up the heart and we teach valves. The pulmonary semilunar valve is a pulmonary valve that is located at the opening of the right ventricle and the pulmonary trunk. So this is your semilunar valve. Right? This is in between the right ventricle and the pulmonary trunk before it goes all the way into, when it gets pumped out of that ventricle into that pulmonary, the pulmonary trunk and into the lungs. And what does it do when it gets to the lungs? It takes all that CO2, exchanges it with O2, and it comes back to the heart, which we'll discuss when we get into the left side of the heart. So the left atrium is, again, one of the top chambers on the left side. It makes up the heart's posterior surface, and it receives oxygen-rich blood from the lungs through the pulmonary veins. So again, the pulmonary veins are the only veins in the body that carry oxygen-rich blood. Okay, usually veins, again, carry deoxygenated blood. So this is a test question as well. It opens into the left ventricle through the left atrioventricular valve. This is a bicuspid valve. So the bicuspid is, again, on the left side, right? And the mitral valve is another name for the left AV valve. So these are used, bicuspid and mitral use the same. We're talking about the left ventricle, which forms the apex of the heart, again, resting on the diaphragm. The internal walls of the left ventricle have, again, the trabeculae carneae, the papillary muscles, and the chordae tendineae. Pumps blood through the systemic circuit and via the aortic semilunar valve. That's your aortic valve. That's that big red arching aorta on top of the heart. This is the strongest conduction, strongest pump in your heart that allows that blood to circulate throughout the whole body. So this is an animation of the rotating heart. Just to take a look at the inside, you can see those cords in the ventricles at the bottom. As you can see, these cords here. And all right, see, as you can see at that angle, very difficult to see. It's not quite straight up and down. There's not exact angles at these, but we'll get some other looks at it. You stop it there. You Stop it right here. So this is your right atrium, this is your right ventricle, this is your left ventricle, and your left. As you can see here, this is your inferior vena cava. This is your aorta. Okay, difficult to actually pick out from this angle. Let's go ahead and go on to the next slide. Do some better pictures. But here's another gross anatomy. This reviews. This is the actual backside, right? So this is the back looking as you were looking at someone's back through their body, and you have your inferior vena cava. This is actually the inferior view. The surface shown rests on the diaphragm, and so you just have to orient it. This is your right atrium, right? This is your superior and inferior vena cava going into the right atrium, and there's your left pulmonary veins that carry oxygenated blood. Here's your left pulmonary artery that carries deoxygenated, or pardon me, the left pulmonary artery and this left pulmonary vein, these carry oxygenated blood, right? This pulmonary artery carries deoxygenated blood. So again, these two are the only that are switched around, right? The rest of the body, if it's an artery, carries oxygenated blood, and if it's a vein, carries deoxygenated blood. So know these two, differentiate these two. They'll be on the test. Know that the apex is actually at the bottom of the heart. It rests on the diaphragm. And just orient that real nice for you. As you can see, that's really obvious picture of the aorta. Here are your atriums up top. Okay, as you can see in the ventricles, you have these chordae tendineae right in through there on both sides. And you have your pulmonary valve right in through there. And where is that going to come from? It's going to come from your right ventricle as it pumps into that pulmonary artery, right? Here are your heart valves. Your valve structure, each valve is composed of the endocardium with connective tissue core, and the atrioventricular valves between the atria and the ventricles. So that's your AV valves, right? Your right AV valve is your tricuspid valve. Your left AV valve is your bicuspid mitral valve. So that's communication between the upper chambers and lower chambers, right? Your atrioventricular. Ventricular. So your right AV valve, again, is your tricuspid, and your left AV valve is your bicuspid or mitral valve. You have aortic and pulmonary valves at the junction of the ventricles and the great arteries. So this hopefully organized things a little bit more for you on the heart. Let's talk about the cardiac skeleton that surrounds all four valves. It's composed of dense connective tissue. And these functions of the cardiac skeleton anchors these valve cusps, prevents overdilation of valve openings, and main point of insertion for cardiac muscle. It's attachment points for the cardiac muscle and blocks direct spread of electrical impulses. Here are your heart valves. This is your anterior portion of your heart valves. As you can see, the top one is your pulmonary valve, right in through there. Below it is your aortic, followed by your mitral and your tricuspid. So remember, your tricuspid, again, is on the atrial side. Your mitral side is on your, your right side of the heart. Your mitral is on the left side. And we'll get a better orientation for you. This is your anterior portion. So this tricuspid is your right atrioventricular valve, and your mitral is your left atrioventricular valve. Remember, the mitral goes on the left, and the tricuspid goes on the right. That's what you need to know about that. And we'll get into this aortic valve and pulmonary valve in a few. As you can see, function of the atrioventricular valves, you can see the blood, as you can see on one, the blood is actually returning to the heart, fills the atria. And that's up the right side of the heart, pressing against the AV valves. The increased pressure forces the AV valves open. As the ventricles fill, the AV valve flaps hang limply into the ventricles. Okay, and so the direction of blood flow and that force actually allows those ventricles to fill, and the atria contract, forcing additional blood into the ventricles. And that way, the ventricles get filled with blood on both sides. On this side, you're going to have deoxygenated blood, and on this side, you're going to have oxygenated blood. So there's your direction of blood flow from your atrium. There's your cusp of the atrioventricular valve, your chordae tendineae that holds things like a flap and holds tension, and your papillary muscles that hold those cords in place. The function of the atrioventricular valves: one, the ventricles contract, forcing blood against the AV valve cusps, and the AV valves actually close at that point, not allowing any more blood into the ventricles. The papillary muscles contract, and the chordae tendineae tighten, preventing valve flaps from everting back into the atria. So once that takes place, the blood is filled in both ventricles, as you can see, and the semilunar valves, as the ventricles contract and the intraventricular pressure rises, the blood is pushing up against the semilunar valves and against forcing them open at that point. Okay, it's either going to go into the pulmonary or the aortic circulation. And then as the ventricles relax and the intraventricular pressure falls, the blood flows back from the arteries, filling the cusps of the semilunar valves and forcing them to close. So what an amazing system. A lot of valves. Whoever created this must have been smarter than us. Very, very cool system with valves and life-giving oxygen and carbon dioxide and that whole working system. Heart sounds. So your lub-dub are the sounds of the valves closing. The first sound of lub, those are the AV valves closing. And the second one, the dub, is your semilunar valves closing. So just remember that first sound, thump, thump, right? That AV valves are closing. The second, again, semilunar valves closing. It's important. Okay, here's another picture. Again, we can touch on, you know what the tricuspid and the mitral valves are there for. One's on the left side. We reviewed that. If you want to revise that, go back a few slides. Now, we're more familiar with the aortic valves and the pulmonary valves and what they do. And the heart sounds. Each valve sound is best heard near a different heart corner. So the pulmonary valve is the superior left corner, and the aortic valve is a superior right corner. So when you put a stethoscope up to the sternum, you're either going to go to the left side or the right side to hear the pulmonary and aortic valves. And we're going to cover that in other medical training in your medical diagnosis or your diagnostics course. You'll be covering this with a stethoscope. Your mitral bicuspid valve is at the apex. So again, the apex is where? It lies level with the diaphragm, right? It's resting on the diaphragm. That's your bicuspid valve. Your tricuspid valve is the inferior right corner. Okay, so this is where, if there's a valvular problem, you can pick it up by listening with a stethoscope. So this is just what I talked about. You have your aortic valve sounds heard in the second intercostal space, the right sternal margin. So second intercostal space, right in through there, that's your aortic valve. Your pulmonary valve is going to be directly across in the second intercostal space, and then go down to the fifth, towards the apex of the heart, you're going to hear your mitral valve. And that's actually in the fifth intercostal space, in line with the middle of the clavicle. So that's mid-clavicular line. So take your clavicle, over here, mid-clavicular, fifth intercostal space. That's going to be your mitral valve. And your tricuspid valve is going to be at the sternal margin, so right up against the sternum in your fifth intercostal space. And you're going to say, well, why is this one lower on this side? I thought it was fifth. As you can see, the ribs start here, but they go down this way. So this one here is level with the fifth, right? Because it's mid-clavicular line, so it goes down. The fifth rib is going to do this. Or right next to the sternum, it's basically a straight shot. Pathway, let me go back up a couple slides. Let me pause it here. So this is really good to know, especially as an acupuncturist. You know, you use a stethoscope. It's in your scope of practice. You can actually listen to bruits actually in the skull. You can listen to bruits throughout the chest and in this area. We're going to cover bruits again in your diagnostic portion of your courseware. But if you need to revise this for valves, go ahead and refer to this slide. So the pathway of the blood through the heart. The beginning is with oxygen poor blood in the superior and inferior vena cava. And where is that? That's the right side of the heart. That's your right atrium. The blood draw passes through all structures sequentially. So the atria contract together and the ventricles contract together. So what you need to know about this slide is that the beginning with oxygen poor blood in the superior and inferior vena cava, returning from different portions of the heart. So the heart is a double pump, and each side is supplying its own circuit. So this slide demonstrates the superior vena cava and inferior vena cava. All right, it shows in order where the deoxygenated blood comes in the right atrium, fills the right ventricle over through the tricuspid valve into the right ventricle. Then the ventricle contracts and sends that up through the pulmonary trunk, which is oxygen poor blood, up to the lungs. And the lungs do their thing and do their systemic capillaries and exchange that CO2 with O2, brings it back, right, to the heart. And essentially what it does, it exchanges there, brings it back to the heart into the left atrium, where the left atrium is then filled with blood, and then goes down to the left ventricle through the mitral valve. And then the left ventricle contracts, and it goes, oxygenated blood is pumped through the aorta up to the different tissues of the body. And then it repeats itself. The oxygen-rich blood is delivered to the body tissues through the systemic circuit. You have your systemic capillaries. When we run out of O2, the oxygenated blood goes back up to the heart again through the inferior vena cava or superior vena cava. Okay, so follow this to revise that system. Just revise this slide. The heartbeat, normal, 70 to 80 beats per minute at rest. And systole is the contraction of a heart chamber. Diastole is the expansion of a heart chamber. So systole and diastole also refer to the stage of heartbeat when ventricles contract and expand. So 70 to 80 is sometimes very high in people, all right? You know, a lot of folks are fit even into their 60s and 70s. So I would anticipate even folks in their 50s and 60s, a lot of them that still work out, and you could actually get you see their heart rates around 60 to 70, even sometimes the elite athletes, you know, below 50, in between 50 and 60. Especially your marathon runners, things like that. But also what I wanted to bring across is that when they come into the clinic, you want to you don't want to take vitals right away. They might have climbed a flight of stairs, they just got out of traffic, their blood pressure is going to be off, their heart rate is going to be off from a normal resting heart rate and a normal resting blood pressure. So you may want to wait a little bit. Hopefully they've been waiting for 15 to 20 minutes before they got seen. And especially if it's on their first appointment, you want to make sure you get a good set of vitals. Get their pulse, get their blood pressure, weigh them, and annotate all of those vitals, even their respiratory rate. Okay, the structure of the heart wall, what's that look like? So the walls differ in thickness. Your atria, which is your top two chambers, are thinner. Your ventricles are thicker because they've got to pump harder. And they differ in thickness. Your systemic circuit, right? Longer than pulmonary circuit. Your pulmonary circuit's pretty short. It's just from your heart to your lungs. But your, the other ones offers greater resistance to blood flow. So understand that it's got to go throughout the body. Needs that strong contraction from that left ventricle. So again, the left ventricle is 3 times thicker than the right ventricle. It exerts more pumping force, and it flattens right ventricle into a crescent shape. Imagine that, being that powerful to take all that tissue and flatten it into a crescent shape. So here's the anatomical differences between the right and left ventricles. As you see, your right ventricle, all it needs to do is pump it up to the lungs through the pulmonary artery, right? Your left ventricle needs this much thickness to get enough pressure to pump and throughout the body. And here's your interventricular septum that separates the ventricles. Cardiac muscle tissue forms the myocardium. It's striated, like I said. And the only other place where striated muscle is your skeletal muscle. So, and like skeletal muscle, contractions pump blood through the heart and into the blood vessels, and contracts by sliding the filament mechanism. The cardiac muscle cells are short, branching, and have 1 or 2 nuclei. So multinuclear, they're branching, and they're short. Okay. You also have, like I said before, intercalated discs. Under a microscope, you can see them. You also have cross striations. That's how you can tell the difference between cardiac muscle cells and skeletal muscle cells. They're both striated, however, they have their differences. Cardiac muscle tissue, cells join at the intercalated discs, there you have it, and they have complex junctions and form cellular networks. And cells are separated by the delicate endomysium and binds adjacent cardiac fibers together. This also binds, it contains blood vessels and nerves through the endomysium. I mentioned intercalated disc a few times already, but these are complex junctions. And they're adjacent sarcolemas that interlock. And there's 2 distinct regions, the fascia adherens, which are long desmosome-like junctions, and they have gap junctions. So these gap junctions are made to communicate with each other. These fascia adherens are long desmosome-like junctions that adhere from one cell to another. They're made to adhere from one cell to the other cell. So here, as you can see, it's multinucleated. You have your intercalated discs up top, and you have your gap junctions that are made to communicate, and you have your fascia adherens that actually adhere cell to cell, right in through there. Here's your cardiac muscle cell and your intercalated disc here, as you can see. You have your nucleus and your sarcolemma, and we'll get into those Z discs later when we talk about muscle tissue. You have your mitochondria and your T tubules that allow for contraction. You have your I band, A band, and your other I band. Okay, from I band to I band, you have your A band, and then you have your Z disc. Okay, we're going to get into that when we talk about the sarcolemma with muscle tissue. But we'll use that from, we'll wait for muscles to get to that. So there is your cardiac muscle. And the mechanism of contraction is triggered to contract by calcium entering the sarcoplasm. And it signals the sarcoplasmic reticulum to release calcium ions. The ions diffuse into these sarcomeres and trigger the sliding filament mechanism between those bands that we saw. And some of them shorten, some of them stay the same. The I bands stay the same, the rest of them change in length, hence the contraction. The mechanism of contraction, not all cardiac cells are innervated, and they will contract in rhythmic manner without innervation. This is called inherent rhythmicity and is the basic for rhythmic heartbeat. The conducting system, the cardiac cells, the cardiac muscle tissue itself has intrinsic ability to generate and conduct impulses. These signal these cells to contract rhythmically. And the conducting system is a series of specialized cardiac muscle cells called the SA node and sets the inherent rate of contraction. That's your SA node, your sinoatrial node. From the SA node, from the sinoatrial node, the internodal pathway to the AV node, the AV node to the AV bundle, and you're getting down to the Purkinje fibers. So the AV node to the AV bundle, and then the AV bundle to the bundle branches. So these bundle branches into the subendocardial conducting network, and these are called your Purkinje fibers. Purkinje fibers. So here's your SA node starting from 1. This is the pacemaker that generates the impulses right up through here. As you can see, it's located just inferior to the superior vena cava in the right atrium or right in that tissue. Okay. After it generates those impulses, pause 0.1 seconds at the atrioventricular node, which is right in through here. Works its way down to the AV bundle, which is 3, and connects the atria to the ventricles. These bundle branches, the left and right bundle branches, conduct the impulses through the interventricular septum, this long septum here, this interventricular septum. As this moves its way around, the subendocardial conducting network stimulates contractile cells of both ventricles. And this is where you're finding your Purkinje fibers in your subendocardial conducting network. So again, the sinoatrial node is its own pacemaker. We can conduct, our body can conduct our own electricity, which is amazing, through the SA node, onto the AV node, into the atrioventricular bundle from left and right, and onto the bundle branches and the Purkinje fibers. Very interesting. And the innervation, the rate is altered by extrinsic neural controls of visceral sensory fibers and parasympathetic fibers and sympathetic fibers. I think as we discussed before, your body's in constant flux between parasympathetic and sympathetic depending on your activity, what you're experiencing, your emotions, and what's going on. Just remember, your parasympathetic is rest and digest. Your sympathetic is not so much. It's actually you're actually worried, stressed, or you're reacting to some type of stressful situation, which could be anything from leaving your house to getting your car in traffic. So we need to find more parasympathetic time for our self-care. Understand that nerves pass through the cardiac plexus And the parasympathetic fibers, branches of the vagus nerve, again, these are your rest and relax, your decreased heart rate, and these parasympathetic fibers are restricted to your SA node, your AV node, and the coronary arteries. So that's good to know. We have our own pacemakers, and we do more time in the parasympathetic allows us to rest or relax a little bit more. However, the sympathetic nerves travel to the heart from the cervical and upper thoracic chain ganglia, innervate both the SA, AV node, and coronary arteries, same as the parasympathetic, but they also innervate cardiac musculature throughout the heart. What's it going to do? Of course, it's going to increase the heart rate and the strength of contraction, because when your body needs it, it needs it. And so it's going to increase that strength of contraction. It's going to increase your heart rate. It's going to do a lot of other things. We're talking about the heart now. So understand it's controlled by both the parasympathetic and sympathetic nervous system. You also have autonomic input controlled by the cardiac centers and the reticular formation of the medulla. So the cardio-inhibitory center influences your parasympathetic neurons, and your cardio-acceleratory center, you see it right now, it says it right there for you, accelerate. And your cardio-acceleratory center influences your sympathetic, which is going to increase heart rate. Inhibits, accelerates. So if you saw that on a test, you'd be able to differentiate that. Your autonomic innervation of the heart, as you can see this diagram, you see there's a big connection. The blue represents your parasympathetic fibers, and your green represents your sympathetic fibers. Okay, and the gray is your interneurons. So we discussed the nervous system in the past. So if you take a look at this diagram and follow it, you have your dorsal motor nucleus of the vagus nerve. Okay, that's your dorsal side. Okay, that's the vagus nerve. It's a parasympathetic. It decreases the heart rate, right? And then this is your parasympathetic, right? Your sympathetic coming from the front, right? The anterior horn, right in through there. Here's your cardio-inhibitory center. This is your cardio-acceleratory center. It ignites this area here and goes through the sympathetic trunk ganglion and goes to the SA node, AV node, and actually works its way all the way down to the muscle tissue itself. And so it has like a stronger connection to increase that heart rate. Okay. All right, we got about another 6 or 7 slides, not much to part 2. So we'll go ahead and finish the heart off today. And as you know, the heart is very important. It's kind of the baseline of our life, right? So it makes everything work. It's a centerpiece. It's our Shen. It's our, when someone's Shen is disturbed, it's probably due to lack of oxygen to the brain, right? So all this could be associated with Western medicine as well. And there's a lot of crossovers. There's a lot of interesting concepts involved with the heart. Let's go ahead and continue with this lecture. So the blood supply to the heart. So you have your own, the heart has its own coronary arteries, and it's the blood supply to the muscular walls and tissues of the heart. You have your right coronary artery and your left coronary artery. And these arise from the base of the aorta, from the top of the heart, and run in the coronary sulcus. The coronary sulcus. The coronary artery, starting with the left coronary artery, branches into the anterior interventricular artery and the circumflex artery. And the left anterior descending artery is the clinical name for the anterior interventricular artery. This is also left anterior descending. This is where most myocardial infarctions occur. The coronary arteries, the right coronary artery, descends in the coronary sulcus and branches to form the marginal artery, which later branches into the posterior interventricular artery and clinically called the posterior descending artery, PDA. And they anastomose with the left side as well on the other back side of the heart. So the cardiac veins carry deoxygenated blood from the heart wall to the right atrium. Again, our right atrium receives deoxygenated blood from the whole body, even its own heart. Right? So the occipy sulci on the heart's surface, these veins are, you can see them on the surface. If you saw the heart, you could actually see them, right? So, and they're in the sulci, right? And the coronary sinus runs in the posterior part of the coronary sulcus. Returns majority of the venous blood from the heart to the right atrium. And these three tributaries of the coronary sinus are the great cardiac vein, the middle cardiac vein, and the small cardiac vein. So here you can see the veins on the bottom. You have your great cardiac vein. They're on the left side of the heart. Your coronary sinus right there, behind. As you can see, it's covered by muscle tissue. And then the middle cardiac vein. On the right side of the heart, you have your anterior cardiac veins here, and your small cardiac vein that descends, actually, is on the right inferior portion of the heart, moves its way back up. And again, these are all going to dump into the right atrium. Moving up, you have your major coronary arteries. This is your right coronary artery, right? This is your right marginal artery, which is a branch of the right coronary artery. You have your left coronary artery and your left circumflex artery. And it's also your left anterior descending artery, which is where more myocardial infarctions occur. Disorders of the heart, you have your coronary artery disease, you have atherosclerosis, which is fatty deposits causing angina pectoris, causes pain. And if serious enough, you're going to get your myocardial infarction, which is a blocked coronary artery and heart attack. And so a lot of people have no pain or no warning. They have silent ischemia, which is lack of circulation to the muscle tissue. You have heart failure, which is progressive weakening of the heart. The heart can't meet the body's demands for oxygenated blood. CHF, congestive heart failure. We see a lot of those patients just as they get older. Heart enlarges and the pumping efficiency declines. The pulmonary arterial hypertension is enlargement and potential failure of the right ventricle. Disorders of the conduction system. You have arrhythmias, that's why we have an EKG. And the variation from normal heart rhythm, it's not exactly, they can look at a rhythm and see what's going on inside the heart at the electrical level. Your ventricular fibrillation is rapid, random firing of electrical impulses in the ventricles. Results from crippled conducting system and common cause of cardiac arrest. Your atrial fibrillation, which is your top two chambers, right? The impulses circle within the atrial myocardium, stimulating the AV node, okay, right in the atrial myocardium, and promotes formation of clots. And this leads to strokes. And it occurs in episodes characterized by anxiety, fatigue, shortness of breath, and palpitations. AFib, VFib, right? And so the development of the heart Um, the heart folds into the thorax region about day 20, 21. Okay, this is when you're conceived, right? Or this is when you're a fetus. The heart starts pumping around day 22. So even as early as day 22, the heart is actually pumping, and the earliest heart chambers are unpaired. So they develop their septums, they develop their atrias, their atrial septums, and their ventricular AV septums, and from tail to head, the chambers are the sinus venosus, the atrium, the ventricular, and the bulbous cordus. These are all embryological um, items that either dissipate or form into other adult tissues. So the sinus venosus will become a smooth-walled part of the right atrium, the coronary sinus, and the sinoatrial node. So that's important. And also contributes to the back wall of the left atrium. The atrium will become the ridge parts of the right and left atrium. The ventricle is the strongest pumping chamber and gives rise to the left ventricle. And the bulbous cordus and truncus arteriosus, what do you think this is? Truncus arteriosus. It's a big word that gives rise to the pulmonary trunk and the first part of the aorta and gives rise to the right ventricle. So these are all embryological and turning into the adult anatomical features. Yeah, so this is a lot of cool information. You won't be held accountable, but it's kind of cool to talk about. In day 20, you have your endothelial tubes begin to fuse. You have your tubular heart and different parts of that tubular heart. Heart starts pumping. There's really no septums or anything in there yet. Just an entranceway and an exit way. And you have your venous end, and then you have your arterial end. And nothing's really going on much in there. The heart continues to elongate and starts to bend. Then the bending continues as the ventricle moves caudally and atrium moves cranially. It does a 180-degree twist and all these other different twists, and then the bending is complete, and you have a functioning heart with forming foramen ovales and septums and almost an adult heart, not quite yet. The congenital heart defects that can be traced to month 2 of development. Most common defect is, like we mentioned before, the ventricular septal defect. And two basic categories of the defect is inadequately oxygenated blood reaches the body tissues, or the ventricles labor under increased workload. So, and some of these folks, it's quite apparent. Some of them don't know about it until later in life, and some people elect just to maintain it. Some people elect to go have surgery done, depending on the severity. So here's your ventricular septal defect. The superior part of the interventricular septum fails to form, thus blood mixes between the two ventricles, and more blood is shunted from the left to the right because the ventricle is stronger, right? We know that that muscle is stronger. So very common, 1 in every 500 births. Then you have the transposition of the great vessels. The aorta becomes the right ventricle. The aorta comes from the right ventricle instead of the left ventricle. So everything's switched around. The pulmonary trunk from the left results when the bulbous cordus does not divide properly and unoxygenated blood passes repeatedly around the systemic circuit, while oxygenated blood recycles around the pulmonary circuit. And this occurs very commonly too, 1 every 1,000 births. Then you have your coarctation of the aorta, and it's a part of the aorta is narrowed, increasing the workload of the left ventricle. This occurs in about 1 in every 1,500 births. It's more common over here. It's more talked about, at least, to the tetralogy of Fallot. You can have multiple defects. There's all kinds of things going on. Tetra means 4, so the first is going to have the pulmonary trunk is too narrow, and the pulmonary valve is stenosed, so it's skinnier, right? And this is going to result in hypertrophied right ventricle. So you're going to have a larger right ventricle to pump all that deoxygenated blood, and then the ventricular septal defect you're going to have, and the aorta opens from both ventricles. So that's the tetralogy of flow. You have a hard time. Baby gets cyanotic for some reason. It's hard. The baby's not doesn't really starts crying when you feed them. They get blue. They get fits. This is called tetralogy of flow. The heart in old age. The heart usually functions well throughout life. Of course, regular exercise increases the strength of the heart, and the aerobic exercise can help clear those fatty deposits in the coronary arteries. The heart in old age, age-related changes, of course, you're going to have hardening and thickening of the heart valve cusps, which decline in cardiac reserve. You're going to have fibrosis of the cardiac muscle. And that concludes our lecture of the heart. So I will be sending out a few more pre-recorded lectures. And also send out a study sheet to prepare for your final. By the end of the week, you'll have it. So I look forward to seeing you this Friday, and have a great week. Take care.